Welcome, everyone. It's Grand Rounds time, and we're very fortunate to have with us a very special person, Dr. SNIFF Watson. And I'd like to tell you a little bit about him. He received his BA cum laude in English Literature in Millsaps College. He got a Master's of Divinity at Harvard. He has an MA in Clinical Psychology from the University of Mississippi. He did his clinical psychology internship with the neuropsychology specialty track at the University of Florida. He got his PhD in psychology with a concentration in clinical neuroscience and neuropsychology at the University of Mississippi. From 1999 to 2002, he was an NIH Senior Fellow Trainee, an acting instructor in the Department of Psychiatry at UW and the VA. From 2002 to the present, he's an assistant professor at the Department of Psychiatry at UW. And as he told me, he's keeping his fingers crossed as he's applied for promotion to associate professor. And we will all cross our fingers for him. Will everyone raise their hands with crossed fingers? Yay, Dr. Watson. We're for you. He moved to Seattle following internship in 1999 to complete a postdoc fellowship with Dr. Suzanne Kraft. His current responsibilities relate to research and supervision of clinical psychology interns. He's recently been appointed to the IRB at the VA Puget Sound. In graduate school, his research focused on the psychopharmacology of social separation in young chickens. Chickens. And he still maintains an interest in animal research. However, his predominant interests since have been related to the neuroendocrinology of Alzheimer's disease, in particular the role of insulin and insulin resistance in the neuropathology and the development of cognitive symptoms. In the last 2 years, he's developed additional interests in the neuroendocrinology of Parkinson's disease. His current project is a pilot study examining the effects of intranasal insulin administration on biomarkers in spinal fluid and plasma, as well as potential improvement of cognitive impairment of Parkinson's disease. Thank you very much for coming to speak with us.
Thank you. It's good to be with you this morning. The focus of today's talk is to give to start with a general overview of Parkinson's, very brief, things that I really want to remind us of rather than teach us. To talk about non-motor symptoms a little more, because I think that we're aware of them, but they're frequently out of sight and out of mind, and that's a big mistake. And then to talk about one particular non-motor symptom, cognitive impairment, and to talk about the research project that I am involved in and really excited about. And through the talk, you'll find that there are a lot of people who are very energetic. I am very earnest, more so than energetic, and so I'll try to look you in the eye as I talk. This is the original essay that started the ball rolling on Parkinson's. I just show it because I think it's a wonderful piece of historical arcane literature. And then I want to remind us first of the pathology in Parkinson's. There's neuronal loss, but the primary pathological hallmark is Lewy body inclusions found in the substantia nigra, the locus coeruleus, the basal forebrain, and the cerebral cortex. This is what a Lewy body in the substantia nigra looks like. If you look, it is very round, and it's got a halo around it, and that's a classic Lewy body in the substantia nigra. This is the substantia nigra of a healthy older adult, and you see there's a black stain here that is the substantia nigra. Substantia nigra, you remember, means black substance. This is the substantia nigra of a patient with Parkinson's disease, and the black stain is absent. So that's what you would classically see on autopsy. The epidemiology, Parkinson's is not nearly as common as Alzheimer's disease. It is age dependent both in terms of prevalence and incidence. At age 70, the prevalence is about 0.5% in the general population. It's slightly more prevalent in males than females, about 3 to 2. Now, something that I especially want to remind us of when we talk about symptoms of Parkinson's disease is that Parkinson's disease symptoms have several sources. There's the disease itself, but there's also the medications that we give patients with Parkinson's that exacerbate symptoms, and there's aging. So if we talk about cognitive symptoms, attention and memory loss, on the one hand, the disease has certainly effects on attention and on memory. But we also have to think in terms of aging, because normal people as they age become more distractible and less able to focus naturally. And we also have to think in terms of the medications, because the medications that we use for Parkinson's induce daytime somnolence and disturb sleep at night. So we get a person who normally is more distractible in aging, put them on some meds that increases their daytime sleepiness, and then they have this disease. And so as we do cognitive research, it's important to keep this in mind and tease these different effects apart. Diagnosis of Parkinson's is based primarily on motor symptoms. According to the UK Parkinson's Disease Society Brain Bank diagnostic criteria, which are standard criteria in many organizations, bradykinesia is really the sine qua non. And then at least one of the other following symptoms: muscular rigidity, rest and tremor, postural instability. There's some supporting criteria as well that include unilateral onset rest and tremor, progressive disorder, and response to levodopa. So those are all involved in making a diagnosis of Parkinson's. But Parkinson's is more than a movement disorder. This is the AAN, American Academy of Neurology practice parameter that's recently been published that talks about non-motor symptoms, and they have another practice parameter as well on non-motor symptoms. But what I want to point out is non-motor symptoms are integral, troublesome, impact activities of daily living. And this is really important, under-recognized by healthcare professionals. Dr. Jim Leverance was telling me of a patient that he recently diagnosed with Parkinson's disease, who for 4 years had been treated for arthritis as a primary symptom. And he came to Dr. Leverance, and Dr. Leverance was able to put that in the context of Parkinson's, and the arthritis medications had not worked, but treating him for Parkinson's reduced his pain. So when we think of non-motor symptoms, this is an article that was published by Martinez Martin in 2007. Of 550 respondents in a worldwide survey, 4 symptoms were reported by more than 50% of the respondents. 19 symptoms were reported by 25 to 50% of the respondents. So as we think about Parkinson's disease, it's important to think about a disease that is not simply a motor disease, but has numerous other complications that in fact in some ways can impact life more severely than the motor disorders. And you're going to find that I think that cognition is one of those symptoms that has a major impact on quality of life in Parkinson's. Now, it would be easy to say that these non-motor symptoms appear late in the disease. But in the same article, they looked at duration of disease and the number of symptoms that were present. And in people who had duration under 5 years, they still were reporting a mean of 8.5 non-motor symptoms that went up as the disease progressed. And over 14 years, they were reporting nearly 13 symptoms on the average. So non-motor symptoms are a major issue in Parkinson's disease. Cognitive symptoms are very common in Parkinson's disease. The estimates vary rather widely, but they are in between 30 and 80%. Now, there is evolving a cognitive classification in Parkinson's disease that we need to be aware of. We can think of Parkinson's disease without cognitive impairment. And in fact, if you've read the original Parkinson's article from 1817, Dr. Parkinson said that there was no cognitive impairment in the disease. But what we're finding is that there's a common dementia that we call PDD, and an in-between state that's called CIND, cognitive impairment non-demented. This is different from Alzheimer's disease because there's not an invariable progression to dementia, but it is very common. The cognitive impairments in Parkinson's disease are the most common ones are impairments in complex attention and executive abilities, particularly the ability to categorize, to persevere on a task, to switch when the perseverance is not optimal, inhibition of prepotent responses, working memory and timing or speed. But in addition, there are impairments in memory, particularly on list learning, and learning there is a little different in this context. It means immediate learning or word acquisition. With a Parkinson's patient, particularly early on, you might see a slow acquisition of words on a list across repeated trials, but after they've encoded the words, they're able to recall them, particularly if they have cues, whereas an Alzheimer's patient would not be able to encode them. So this is list learning. Another interesting difference between Alzheimer's disease and Parkinson's disease is that Parkinson's patients have deficits in remote memory without a temporal gradient. What that means is that a Parkinson's patient is more likely to lose information from the distant past than an early or mid-stage Alzheimer's patient, who can perhaps not tell you what happened 5 years ago or 5 minutes ago, but who can tell you what happened 50 years ago. And then retrieval is an issue, and when we aid retrieval with cues, the Parkinson's patients benefit and Alzheimer's patients don't benefit so much. Visual perception is a fairly new area of study, and it includes deficits in perception, praxis, and visual motor activity. Language, I have question marks here because there are language deficits, primarily in the ability to name, but that's a very general impairment seen across many different dementias and head traumas, and so I think it's more general than Parkinson's specific. With verbal fluency, Parkinson's patients do have a deficit, it appears, in the ability to name words that start with a given letter. But the reason the question marks are here is that I'm not convinced that's a language deficit so much as a frontal executive deficit, a retrieval strategy deficit. Here in Seattle, we have looked at some of these deficits, and this is a project that Dr. Jim Leverance is in charge of that I've worked with Jim putting together. It focuses on Booth Gardner Parkinson's Care Center patients. There are 68 non-demented patients in this sample, and that's important. These are not patients that have general significant decline. They had neuropsych testing, and we did principal components analysis on the data to reduce the number of variables, the number of tests, into domains. And this is not showing up, unfortunately, but I tell you what it is. This is a factor loadings graph. And if you could see it, there would be a line right here. Everything except trails A and B would be below the line, and trails A and B would be above the line. What that says is that there is a factor based on trails A and B that's frontal executive, and it looks pretty exclusive. The same thing with story recall, both immediate and delayed. Everything else, these were below the line, everything else was above the line, so it seems to be a pure loading on memory. Judgment of line orientation, I'm going to show you a picture of what it looks like, but it's visual spatial skill and verbal fluency. So there are 4 factors that popped out, and they relate to those factors that I talked about earlier. And we hope to submit this in the next couple of months for publication. This is trails B, in case you haven't seen it. It's an interesting test. It's an old test. It's very simple. You give somebody a pencil and tell them to start at number 1 and draw a line from 1 to A to 2 to B and so on until they get to the end. We score it for errors and speed. And it takes the intact ability to switch between 2 different tasks. One task is number sequencing, and the other task is letter sequencing. And so the interesting thing about this task is that it's the task that's most highly correlated with driving abilities. And so someone who has difficulty doing this task is probably going to have difficulty driving. This is judgment of line orientation. There's a booklet, and there would be a spiral binding right in here. You ask people to look at these 2 lines and then to look at these 11 lines and pick out the ones from up here that these match. Which ones are they, by the way? 5 and 9. And verbal fluency is a very common test among neuropsychologists. We ask people to name all the words that they can think of that begin with a given letter or that belong to a certain category. The phonemic verbal fluency is the letter verbal fluency, and the category verbal fluency is semantic verbal fluency. The clinical lore that's been tested a bit, but not tested as much as some of us would like, is that Parkinson's patients have more trouble with phonemic verbal fluency. It would be true of patients with vascular disease as well. AD patients have more trouble with semantic verbal fluency. So when we look at summaries of neuropsych scores, one of the things that we always look at is the standard score on animals versus FAS. FAS is phonemic, animals is category, and one of us will say that looks like an Alzheimer's pattern, and it happens so often. We laugh when we do it. One of the studies that I am working on now is a study on clustering and switching in verbal fluency. There are 2 important strategies to do verbal fluency. One is called clustering, and that's grouping words by sound category, some strategy to help you call up words. So you may think of dogs, and then Bassets, Beagles, German Shepherds, Greyhounds, and you run out of dogs, and so you switch to fish, and you think sharks, bass, brim, crappie, and you run out and you switch again. Alzheimer's patients are impaired on clustering, but it's not thought that PD patients are as impaired as Alzheimer's patients on clustering. Switching is the ability to change when it's less efficient to remain in the category. So the most efficient strategy for coming up with words either by category or by phonemic letter is to run through the clustering, switch immediately when the clustering begins to wane, run through it, and switch. And as I say, the Alzheimer's patients are thought to be impaired on clustering, and switching is an impairment for both AD and PD patients. We're going to test this. We're going to look at 500 to 600 sets of protocols of older men and women that will include Parkinson's disease patients, both non-impaired, impaired with no dementia, and Parkinson's disease with dementia, AD and MCI, and no other neurodegenerative disease. We're using multiple sites. Data will come from UW, from the Pacific Northwest Udall Center Clinical Core, and from Dr. Kraft's lab. Will come from Emory, Penn, UCLA, and possibly from Rush. The instruments that we'll use will be FAS in animals, and the outcome measures will be clustering and switching. Endpoints and predictions are that AD patients and perhaps MCI patients, which are prodromal Alzheimer's patients, and Parkinson's disease with dementia patients will be impaired on animals. FAS will show impairments in AD patients and Parkinson's disease with dementia and CIND patients. Clustering will be impaired in AD and PDD, possibly in MCI, and sequencing will be impaired, or that should be switching, will be impaired in AD and in Parkinson's disease. Now, what is the incidence of dementia? There have been two important studies that have looked at this. One by Williams-Gray in the UK, in which they looked at incidence of dementia in 126 Parkinson's disease patients at baseline and follow-up 3 to 5 years later. 10% had dementia at 3.5 years from diagnosis, and 57% showed evidence of cognitive impairment. So we see a strong risk for cognitive impairment in this particular study. A much larger study in Norway by Arslan was an 8-year prospective study that included 224 Parkinson's patients, 3,295 non-Parkinson's disease patients, and they looked at dementia according to the DSM-3R criteria at follow-up after 4 years. In the Parkinson's sample, nearly 52% had dementia versus 18.5% in the non-Parkinson's disease sample. So there is a much higher rate of dementia. At 8-year follow-up, nearly 80% in this sample had dementia. So we're talking about a disease that is strongly linked with cognitive decline. The risk factors in the study were hallucinations and akinetic dominant Parkinsonism. Now, there are two studies here in Seattle that I want to point out. One by Tom Montine, who is a neuropathologist here at the U, and the other by Dr. Jim Leverance. The first one is related to markers for Alzheimer's disease in controls, MCI, AD, PD, PDD, and PD-CIND. And the other looks at AD and PD markers in non-demented Parkinson's patients. One of the things that we are struggling with is what is the relationship between Alzheimer's and Parkinson's. And this will show how they are related in some degree. This is the study by Montaigne. He has controls who are under 50 years, controls who are over 50 years, MCI patients, AD patients, PD patients that are not demented, PD patients with mild cognitive impairment, non-demented, and PD patients demented. This is the typical pattern for Alzheimer's patients. If you compare, beta amyloid is reduced and tau is increased. So you can see that it goes from 420 to 216, from 58 to 88 on total tau, and p-tau goes from 21 to 51. So this is the typical Alzheimer's pattern, and it is diagnostic of Alzheimer's disease. What is interesting is that in Parkinson's patients, here in CIND patients, there's also a reduction compared to older controls. And this is significant. The highlighted cells are significant. There's a reduction in A beta, and it's not significant, but it's further reduced in dementia. However, p-tau is not reduced, but it is significantly lower than Alzheimer's disease. And so there are changes in beta amyloid that do not seem to be true of tau in Parkinson's disease. So as we look at Parkinson's disease, one of the things we'll be interested in is how A beta and tau respond to insulin. And if you look, there seems to be a slight progression even further down in dementia, even though it's not significant. These are non-demented patients and how these markers correlate with neuropsych testing. Logical memory is story recall, and logical memory 2 is delayed story recall. Verbal fluency, digit symbol is the ability to transcribe abstract symbols by key and pair them with numbers. And trails B minus A. By subtracting A, which is a simple version of trails, from B, you're able to take out the motor component and get more strictly at the cognitive component. If you look, verbal fluency and digit symbol are the most highly correlated, or significantly correlated with the A beta, BDNF, and the A beta tau relationships. However, tau, as in the previous slide, is not related to performance in Parkinson's. So again, we see that it's A beta primarily that is related both to the disease itself and to cognitive performance in the disease. The points that these two articles make, one is that PD, both CIND and dementia, are associated with low A beta 42 levels in CSF, but not elevated tau or p-tau. Neuropsychological performance is associated with A beta 42 and BDNF, but not with tau and non-demented PD. And cognitive impairment in Parkinson's disease is not associated with the full AD biomarker profile, which is consistent with the neuropath literature. With that as a background, I want to move to SNIFF and tell you about this project. It stands for a study of nasal insulin to fight forgetfulness. Dr. Laura Baker over in the front row is credited with that, and I think it's one of your 2 or 3 best study titles. One of the things that's very interesting is that small peptide or small molecule neuropeptides are taken up from the cribriform plate in the nasal cavity and transported into brain. They are transported along 2 pathways. One is a bulk flow pathway that moves very quickly, and I'll show you a graph of how quickly it moves in just a moment, but along the olfactory pathway. The other is through axonal transport, and it moves much less quickly. But there have been a number of studies now that show that insulin administered to the nasal cavities is taken up and influences behavior. This is a graph that comes from Kern 2002 in Nature Neuroscience, where they gave nasal insulin administration at 0.0 and watched it over time. They also did the same thing with vasopressin and with ACTH and found similar results. As you can see, insulin is elevated. These are concentrations of insulin in lumbar spinal fluid. In 10 minutes, there's an elevation of insulin in lumbar spinal fluid. It's a rather confusing and difficult to interpret drop at 20 minutes, but at 30 minutes it's back up, and it stays up at least to 80 minutes. So insulin is traveling very rapidly from the nasal passages into spinal fluid. The specific aims of the study are to demonstrate that nasal insulin administration will facilitate cognition in middle-aged and older adults with Parkinson's disease, to characterize nasal insulin administration effects on biomarkers in plasma and spinal fluid, and to also characterize glucoregulatory status in Parkinson's patients. Why should this work? Well, it works for several reasons, and I want to point out 3 today. One is that there are cognitive impairments in PD that may be related to insulin resistance. The second is that insulin affects a variety of neurotransmitters, including dopamine, GABA, glutamate, and norepinephrine. A third is that insulin administration facilitates memory and complex attention in older adults with impaired cognition. The first that I want to talk about just briefly are the cognitive impairments in PD we've already talked about, but they may be related to insulin resistance. Insulin resistance is clearly associated with cognitive impairment. We and many others have published on that. And when we replace insulin, insulin contributes to normal memory. We see an improvement in older adults, both in healthy normals and in patients with mild cognitive impairments and patients with Alzheimer's disease. And treating insulin resistance can facilitate cognition. So there have been a number of studies that show that when diabetic status is improved, cognition improves. Parkinson's disease may be associated with insulin resistance. Estimates from Ristow and others are as many as 80% of Parkinson's disease patients have insulin resistance. However, there are other studies in which there's no association. Based on this, we think that insulin resistance may contribute to cognitive impairments in Parkinson's disease. Insulin also affects neurotransmission. As I said, dopamine, GABA, glutamate, and norepinephrine are very important in Parkinson's disease, and they're very important players in association with insulin. This is the circuitry that points out that, as you can see here, it all starts with dopamine transmission, and then it includes GABA transmission as well as glutamate transmission in this circuit. So we think that insulin, by affecting this circuit, may improve cognition and perhaps other non-motor symptoms as well. Evidence includes evidence for insulin and dopamine in the substantia nigra. Insulin receptor loss in Parkinson's is common in Parkinson's disease, and when lesions are induced by 6-hydroxydopamine, which affects dopamine transporters. It modulates pancreatic beta cell loss. Interestingly, when animals are given ICV insulin, intracerebroventricular insulin, it increases dopamine transporter messenger RNA, and on the other hand, hypoinsulinemia, reducing insulin, decreases dopamine transporter RNA and tyrosine hydroxylase, both of which would affect the system. And the dopamine agonist bromocriptine, when given into the cerebral ventricles, improves insulin sensitivity. And so there is an evolving set of evidence to suggest that by giving insulin will have an effect on dopamine. Likewise on GABA. GABA is one of the truly common neurotransmitters. It's the principal inhibitory neurotransmitter in the brain. Insulin increases cell surface GABA A receptor expression. Insulin and GABA exert reciprocal electrophysiological potentiation, and insulin modulates GABA synaptosomal transport. So again, insulin has a potential of having an effect on this system that is commonly damaged in Parkinson's disease. Insulin and norepinephrine are also have a well-known relationship. One of the most interesting things that I've read is that neuronal loss is greater in the locus ceruleus than in the substantia nigra, which means that norepinephrinergic neurons are definitely affected in Parkinson's disease due to cell loss here. Insulin reduces neuronal norepinephrine uptake and norepinephrine transporter messenger RNA levels. IV insulin increases CSF norepinephrine, and that is right. When we give insulin peripherally, it crosses the blood-brain barrier, and it actually increases levels of norepinephrine in CSF, but not in plasma, which is germane to what we're looking at here. And CSF levels were correlated with improved working memory and paraphrase story recall. So there's a reason to believe that giving nasal insulin will do the same thing. Insulin also modulates other neurotransmitter levels and affects glutamate, acetylcholine, and somatostatin. Now, why should intranasal insulin improve frontal executive functions? Here's a very simple model. And dopamine has an effect on GABA, has an effect on glutamate, has an effect on the frontal cortex, and norepinephrine has an effect on the frontal cortex as well. Insulin acts here, 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 here. And so we believe that by giving intranasal insulin, we'll be able to improve cognition. Third, intranasal insulin facilitates memory and complex attention in older adults with impaired cognition. We have three published SNIFF studies. We have three published and one in preparation. Two are acute dosing studies and two are chronic dosing studies. Only the first one involved normal memory and the others involved only impaired memory. The outcome measures are story recall and our word list recall and the STROOP selective attention task. We looked at plasma biomarkers and CSF biomarkers. In our very first nasal insulin study, we had memory impaired subjects, normal control group, all ApoE genotyped. We gave a SNIFF of insulin, 20 units, 40 units, or saline. Everybody came 3 visits and got each dose on a different day. We waited 15 minutes, and you remember I showed you that graph that showed that insulin is up in lumbar spinal fluid in 10 minutes, and they did cognitive testing and a blood draw. Healthy controls didn't show a change. ApoE4 positives, the people who are at risk for Alzheimer's disease by genotype, didn't show a change, but ApoE4 negatives showed 20% and 75% improvement in memory. In the second SNIFF study, we did a similar design that had 4 doses, and this is relative to baseline. The ApoE4 positives again showed no change, but the ApoE4 negatives showed an improvement at the 3 lowest doses. It points out something that's very important to note, and that's the whole idea of pharmacogenetics, that people vary by genotype as their response to medications. This is word list recall in the second study, and it just points out the significant improvement, both in delayed and immediate. This is in the SNIFF 21, which is a 21-day daily dosing. Again, there's an improvement in memory, and there's an improvement here. This is latency to respond, and so a lower latency is improvement. There's improvement here in the STROOP, and here in memory with chronic dosing. Now, this shows plasma levels of beta amyloid in the 21-day study in fasting and in fed conditions. And there's a little difference that's important to point out. A beta 40 goes up when people are fasting. A beta 42 goes down when people are fed, but doesn't change when people are fasting, nor does A beta 40 change when people are fed. The sum total, though, is that the A beta 40 to 42 ratio goes up in both groups, but driven by different species of A beta. This is the preliminary data from the 120-day daily dosing study, and it shows very similar to what we saw in Montine's paper earlier. There are no changes due to this is a change score, percent change from baseline with saline and with 20 international units of insulin. There's no change in tau with either of these. There appears to be an increase in A beta 42 and an increase in the A beta to tau ratio. So what we're seeing is that not only do Parkinson's disease patients have A beta abnormalities, insulin apparently has an effect on them, and that's one of the things that we'll look at in this study. And finally, these are our CSF cytokines levels for TNF alpha, interleukin 8, IL-6, IL-1 beta. And you can see that intranasal insulin administration after 4 months increased levels of CSF cytokines.
Dennis, you might say why you're looking at that.
Okay. One of the things that we know about neurodegenerative disorders, thank you, Richard, is that they are chronic inflammatory conditions. Whether we look at Alzheimer's disease, multiple sclerosis, Parkinson's disease, or in fact when we look at other diseases as well, like diabetes. And there is a strong correlation between inflammatory markers and disease state. In the Alzheimer's literature, it's very clear that beta amyloid and cytokine levels have an effect on each other. Beta amyloid will in fact activate microglia and astroglia, which in turn induces a release of cytokines, which leads to a cascade that increases A beta levels. So there's a loop there. One of the sets of studies that we've done is to look at a drug called pioglitazone. Pioglitazone is an insulin sensitizer that's used to treat diabetes. It has an interesting effect. It's a COX-2 inhibitor, and so it reduces inflammation. And by reducing inflammation, it appears to change levels of beta amyloid. And so that's where all of this comes together. In adults with impaired memory, intranasal insulin facilitated memory and selective attention, modulated plasma A beta levels, modulated CSF tau A beta ratio and cytokine levels, and acute and daily dosing produced similar results. The specific aims of this study are to demonstrate that intranasal insulin administration facilitates cognition in middle-aged and older adults with PD, to characterize intranasal insulin effects on biomarkers in plasma and spinal fluid, and to characterize glucoregulatory status. We will start out in this pilot study with 15 subjects with PD, medication treated, and recruitment will be primarily from the Pacific Northwest Udall Center and the Parkinson's Disease Registry. They will be cognitively intact to moderately impaired. We feel like that's our best chance at showing cognitive improvement. MMSE scores will be in the 50 to 30 range, and age range will be 45 to 90. We'll have a screening visit that will consist of consent, physical evaluation and labs, an oral glucose tolerance test and cognitive screening, and 2 study visits that will include dosing with either insulin or saline in randomized order, cognitive testing, 2 blood draws, and a lumbar puncture. The outline for the study visits look like this. They come in about 8 o'clock. They have a blood draw. They're dosed with insulin. At about 15 minutes later, they get 20 minutes of cognitive testing, another blood draw, and then an LP. Our goals are to complete the pilot study by May and to have something submitted by publication very shortly after that. And then use the grant, or use it for pilot data for grant apps to the NINDS and Michael J. Fox. The things that we're interested in following up with are an extended dose response study. I showed you the second SNIFF, and we want to do that in Parkinson's patients. Daily dosing and functional imaging. As a part of this work, it's very important for me to acknowledge Suzanne Kraft, who's been my teacher and my colleague for nearly 12 years now, as well as her lab members, who are generously many of them in the audience, and to thank Dr. Tom Montine, who is the principal investigator on the Northwest Udall Center, Pacific Northwest Udall Center program grant, Dr. Jim Leverance, who is the principal investigator on the Panook Core C, and Dr. Cyrus Zabadian, who is the principal investigator on the genetics core, to thank NINDS for funding the Department of Veterans Affairs and the VA Puget Sound, and to acknowledge that we are getting devices for nasal administration of insulin from Aeropump in Germany. And thank you very much. Let's see if there are questions from the remote audience. Are there any questions? Yes.
You showed the data with the cytokines going up, and if I understood correctly, your description for background on that, I would have thought that for the cytokines to go up with insulin would be a bad thing. And they're generally associated with depression and stress responses in animal models. So I'm wondering what you think, if I understood that correctly.
You did understand that correctly. The issue with insulin is that insulin will drive cytokines both ways, depending on whether it's a chronic or acute dosing. And in this model, in acute dosing, it definitely drives them up. With this model, I think what I haven't done the statistics on it, and I don't have data of my own to do this with, but I would like to look at the correlation between cytokines and A beta 40 and 42. It appears that A beta 40 goes up with insulin administration. It appears that A beta 42 goes down with insulin administration, and it may be simply a trade-off that we're getting a better A beta 42 profile, and there is more inflammation in vessel walls. But until I do the numbers, it's hard to tell.
One other question.
Oh, sure.
The ApoE4, is there a way to parse out if that's a direct effect of sensitivity to insulin, or if it's a marker for disease severity, or?
We actually have done some work with that, and Suzanne's work and work that I've been involved in identifies ApoE4 minus or negative patients as being more likely insulin resistant. When we look at things like the amount of glucose that in a hyperinsulinemic euglycemic clamp model, where we give a fixed dose of insulin and give a variable dose of glucose to see how efficient people are at disposing of glucose. We find that E4 positives have higher disposal rates than E4 negatives. That shows a more insulin resistant sort of state. We've also looked at CSF to plasma ratios in I believe in 1998 in neurology, there was a study that we published that showed that E4 negatives had a higher plasma to CSF insulin content ratio. So it would be possible to take those data and to look at A beta levels, cytokine levels, and to look at whether insulin resistance is a direct contributor or not. So I think that's a great question, and hopefully out of this pilot study I'll have some of those data to do that with. We're going to look at cytokine levels, A beta levels, and we'll have a measure of insulin resistance on these patients.